me, okay? So today we're going to be discussing certain soft tissue, lesions, okay? So 1 minute. Okay. So can you see me? Can you see my slide? Can you see my slide changing?
Yes, sir.
Okay. So today we're going to be discussing rotator cuff tendinitis. Then we're going to be speaking, basically, we're going to be speaking on rotator cuff disorders. We're going to be studying about rotator cuff disorders. We're going to be talking a little bit about biceps tendinitis and biceps rupture. Okay. So now, initially, what we must study is regarding the muscles of the rotator cuff. So there are 4 muscles which form the rotator cuff, and they are the supraspinatus, the infraspinatus, the subscapularis, and the teres minor. So like you can see on this picture, the teres minor, the infraspinatus, and the supraspinatus, they get attached to the greater tuberosity of the humerus. Okay, so you can see the attachments here. The teres minor is the most inferior one. Then the infraspinatus gets attached to about the middle of the greater tuberosity, and the supraspinatus gets attached onto the top of the greater tuberosity. While the 4th muscle, the tendon of the subscapularis, gets attached on the lesser tuberosity. Okay, so these 4 muscles form the rotator cuff. Now, along with the rotator cuff, you can see on this picture that you have other structures here. So you have the biceps tendon here, which is lying just adjacent to the rotator cuff, and then you have a very important structure there, the acromion. Okay, so now let's go to another picture of the rotator cuff. So here you can see, if you look to your right side, it's the anterior view. So you can see the subscapularis there getting attached to the lesser tuberosity, and then just above that, just behind the coracoid process, you can see the supraspinatus tendon, which is coming and getting attached to the top of the greater tuberosity. And then to the picture on your left, you can see the infraspinatus and the teres minor getting attached to the inferior portion, the middle and the inferior portion of the greater tuberosity. Okay. Now, the first tendon that we will be talking about, which is important for you, is supraspinatus tendon. So this supraspinatus tendon originates from the supraspinatus fossa, as you can see on the left side. So it originates from the supraspinatus fossa, and it comes under the coracoacromial arch, okay, and comes and gets attached to the greater tuberosity. So this tendon can undergo tendinitis following repetitive compression or rubbing under the coracoacromial arch. So as you can see on this picture to the right, that is the coracoacromial arch. So the coracoacromial arch is formed by the acromion and the coracoacromial ligament. Okay, so that's the coracoacromial arch. So when there is repetitive compression or rubbing of the supraspinatus tendon under the coracoacromial arch, then this can lead to tendinitis. Okay, as you can see in that under that coracoacromial arch, or in the subacromial space, you have the tendon and you have a bursa which lies under the acromion. So can you see the picture on your left? There's a swollen bursa there. So when the space inside that arch gets compromised, then the tendon undergoes more compression and rubbing, okay, because of compromised space in that arch. So normally in abduction, the tendon just slides under the arch. But if the tendon is inflamed, or the bursa is inflamed, or if there's a bony outgrowth from the undersurface of the acromion, then the space in that coracoacromial arch is compromised, which leads to repetitive compression and rubbing of the supraspinatus tendon, leading to supraspinatus tendinitis. Now, this rubbing or compression is very common in this window cleaning position. That means when the shoulder is in abduction and internal when the shoulder is in abduction and slight flexion, and when there's a movement which causes an internal and external rotation of the cuff, okay, internal and external rotation, then the cuff comes in contact with the acromion process. For example, this lady who's wiping the window pane, this is known as the window cleaning position. So in this position of slight abduction, flexion, and internal rotation, if there is repeated internal rotation and external rotation movement performed, then this can lead to the impingement of the supraspinatus under the coracoacromial arch. And this also has been called as the impingement position. So you can see on the right side, there's this picture of a cuff, and you can see that the supraspinatus tendon is getting impinged. In this position, it is getting impinged under the coracoacromial arch, okay, which is leading to the tendinitis. Now, the mildest injury, when this type of friction occurs, to and fro movement, and there's a lot of friction under the coracoacromial arch, when the cuff undergoes a lot of friction, the mildest type of injury is a type of friction which results in, when there's friction over the cuff or the tendon, this results in localized edema and swelling. Okay, so this localized edema and swelling is known as tendinitis. Now, when this is it happens for a long time and it is a prolonged problem, or if it is a repeated problem, as the patient ages, the tears develop. So on that tendinitis, when there's repeated to and from movement and there's a lot of rubbing on the tendon, then tears will develop on the tendon. And these tendon tears, sometimes they may heal, but then they heal by scarring, or there's formation of calcium there. So there's calcification or scarring. So what happens is that limited space that was present there, with that thin tendon going back and forth, when there's scarring of the tendon and there's calcification, then that space is again, it is occupied by the scarring, okay, and the fibrosis. So again, the space becomes compromised. Now, this simple process can be summed up as wear. So wear is when there's repeated movement in this impingement position, and then the patient sustains a tear as time goes by, okay? And then the natural process is to try and repair the tendon. So the body tries to repair the tear, okay? So this is brought about by the good blood supply that is usually present in younger patients. So as I told you, young patients, the repair is vigorous and the healing is very, very rapid. So young patients who play a lot of overhead sports, badminton, tennis, and they tend to injure their tendon, or they do a lot of work and they injure their tendon. Here, because of the quality of the tendon and the vascular supply, the good blood vessel supply, the repair is vigorous and the healing is very, very rapid. But once the patient becomes older, then the wear is also more, he has used his shoulder more, and the repair is less because the quality of the tendon itself becomes bad. And the blood supply is also bad, and it is compounded again by hypertension, diabetes, atherosclerosis, and then the healing is lower. And finally, when the tendon undergoes tears, especially if there's a large tear, then that leads to secondary arthropathy. That means secondary, like you can see on this X-ray here, the humerus has shifted up and it is gone and it is abutting the acromion. And you can see that there is a lot of secondary arthropathy or osteoarthritis there of the shoulder. Now, what are the clinical features of rotator cuff problems? They basically depend on the stage of the disorder. So whether it is a tendinitis, whether it is a partial tear, or whether it is a complete tear, it depends on the stage of the disorder. It depends on the age of the patient. Like I said, if you have young patients, then they heal very well and they respond very quickly. And if it is an elder patient, then the tear progresses and the healing is also very, very bad. Now, the vigor of the healing response is also dependent on the comorbid situation of the patient, the age of the patient, the blood supply, everything contributes to the healing response. Now, there can be three presentations in clinical pictures, in clinical features. So one is a subacute tendinitis, the other is a chronic tendinitis, and then finally it can lead to the disruption of the cuff. So when you have the first phase of subacute tendinitis, then there is this syndrome called the painful arc syndrome. So usually a patient who's under 40 years of age, he has pain on and off over the shoulder, and he says that on abduction, the pain, when he tries to abduct his arm, the pain is usually aggravated between 60 and 120 degrees. So this is the angle between 60 and 120 degrees when the tendon, supraspinatus tendon, comes in contact with the coracoacromial arch. So this rubbing under the coracoacromial arch causes this painful arc syndrome. When the patient's arm goes above 120, then this compression, since the shoulder tends to go into external rotation at that position, the compression is relieved. So the patient has relief after 120 degrees of abduction. Now, there are two terms that we must learn when we study about rotator cuff. One is the impingement sign. So this occurs when the patient has pain in flexion, abduction, and internal rotation. So when the patient has pain in flexion, abduction, and internal rotation, you can jerk the shoulder a little bit in this position. And if the patient has pain, this signifies that the impingement sign is positive. Now, another term which is known as the impingement test. So this happens when the pain, see what we do is we inject about 10 ml of 1% lignocaine into the subacromial space, just above the tendon in the subacromial space. So when we inject the local anesthetic there, then the pain decreases. So basically what we understand is the tendon is involved out here. Okay, so if there is a rotator cuff tendinitis and you put 10 ml of 1% xylocaine into the subacromial space, you inject it there, the patient's pain will decrease. So we say that the impingement test is positive. Now, the other stage of the disease is a chronic tendinitis. Now, this patient has recurrent shoulder pain. So he's on and off shoulder pain, and this pain is due to tendinitis and the fibrosis. The fibrosis has occurred because the tendinitis has healed with scarring, there's calcification there, and this also leads to fibrosis, which leads to, again, compromised space in the subacromial space. And again, this again, because of the size of the tendon which is increased, it again rubs under the coracoacromial arch. So this is usually seen in the age group of 40 and 50 years. Okay. And okay, so and here there may be a history of recurrent attacks of subacute tendinitis. So many attacks of subacute tendinitis can lead to this condition of chronic tendinitis. And when there is chronic tendinitis, then because the biceps tendon is very, very close by, you can get signs of the swelling of the biceps tendon also, which is known as bicipital tendinitis. And how do we know this? There will be snapping. So there will be a snapping noise and passive rotation. So when you rotate the shoulder passively, you will get a snapping noise. So the snapping noise usually tells us that you are dealing with a case of chronic tendinitis. Okay, if the shoulder says, if the patient says, when I move my shoulder, I get snapping noise in my shoulder, then we understand that this is a chronic case of tendinitis. Now, finally, what happens is once the tendinitis goes on and the patient does not come for treatment, and as the tendinitis gets aggravated, then it can lead to a partial or a total tear of the rotator cuff tendon. Now, this usually occurs above 45 years, and This patient would have had recurring pain, and now there's this significant weakness. Okay, so this thing about pain and weakness, when you have a partial tear of the rotator cuff, there will be a lot of pain. Okay, but the weakness will not be too much. The weakness will be there, but it will not be very, very weak. Okay, but once the tear becomes total, once there's a full thickness tear, then the pain will be minimal, but the patient will not be able to lift up his shoulder. So yeah, so this is what I was saying. The partial tear, it permits, there is continuity of the cuff. It's only a partial tear, so there is a continuity of the cuff. So the cuff does permit active abduction. In a full thickness tear, active abduction is impossible because the cuff is completely torn. Now, on the X-ray, what do we see on the X-ray? The X-ray in the early stages will be normal because the cuff cannot be seen on the X-ray. The early signs on an X-ray will be erosion, sclerosis, or cyst formation on the greater tuberosity. So like on that X-ray on your left, we can see that the greater tuberosity contains a cyst there. Okay, so you will see an erosion or a cyst or sclerosis on the greater tuberosity. So that's where the attachment of the supraspinatus tendon lies. Okay, and we may see roughening or overgrowth on the anterior edge of the acromion, like those arrows are showing you. This is in an advanced patient. Okay. Now, imaging. When we go to imaging, the ultrasound is quite a useful diagnostic. You can perform diagnostic imaging with the ultrasound, and the ultrasound will tell you whether it's a partial tear or whether it's a large cuff tear. Okay, ultrasound that will tell you. But the ultrasound will not tell you the size of the tear. Okay, very, very, very precisely. So we take the help of the MRI. Okay, the MRI can even tell you regarding the quality of the tendon. So we know the size, the quality of the tendon also is important, because if we are planning repair, then we need a good quality tendon. So these are the diagnostic modalities. The X-ray helps to a certain extent, but the most important ones are the ultrasound and the MRI. Now coming to the treatment. Now once we know, using imaging and our clinical studies, regarding whether there is tendinitis or whether it is a partial tear or whether it is a complete tear, then we come to the treatment. Now coming to the treatment, for conservative treatment in patients with tendinitis, the patients are taught to avoid the impingement position. So basically we teach the patient to avoid working in that position where the tendon gets rubbed under the coracoacromial arch. So you tell them that you can use your shoulder, but you should not use it in the impingement position, because that is going to make the problem worse. Now, physiotherapy is important to build the muscle, the rotator cuff muscle. So you give isometric exercises of the tendons involved, and ultrasound massage, and exercises are performed in the position of freedom. That means in the position where the tendon does not impinge. Okay? And if the pain is not reduced with analgesics, then you can give them a corticosteroid injection in the subacromial space. So this will help reduce the inflammation and the pain, and then the patient can begin to meet the physiotherapist and build the muscles. Now coming to surgical treatment, now what I must tell you is there is a big role of conservative treatment in rotator cuff disorders. All rotator cuff tears do not need surgery. So there is a lot of role of conservative treatment in rotator cuff tears, or basically tendinitis, partial tears, and even in full thickness tears, there's a big role of conservative treatment. And coming to surgical treatment is only performed after a good trial of conservative treatment. So it doesn't have to be strictly 3 months, but there has to be a good trial of conservative treatment. And if the patient is not better with the conservative treatment, then we do a subacromial decompression by doing arthroscopy, or if the surgeon doesn't know how to do an arthroscopy, then you can do an open surgery also. And if there's a partial or a full thickness tear and the function of the patient is compromised, then the patient has to undergo an arthroscopic or an open repair of the tear. Now, this is an example of an arthroscopic repair. So this is a scope. The surgeon's left hand is holding the scope. This is an arthroscope, which is placed in the subacromial space in the shoulder. And through the right hand, the surgeon is using the shaver. And this is how he's cleaning the tear. And then he will repair the tear by using these small portals by doing arthroscopy. If the doctor is not familiar with arthroscopy, then you can do a mini open cuff repair. So depending on the type of the tear, you're using these small anchors here, and you can do a single row repair